So now we're going to talk about shock. So there are four distinct types of shock we're going to discuss: hypovolemic, cardiogenic, obstructive, and distributive. So circulatory failure is really what's happening in shock. Those two things are kind of synonymous. Shock means overall circulatory failure. So the overall result in the body is this significant or severe hypoperfusion or low blood supply to all of the organs and tissues. So really a systemic effect. And this hypoperfusion leads to an insufficient supply of oxygen and nutrients that are necessary for cellular function. And so we start to have a decrease in cellular function throughout the body and all the signs and symptoms that go along with that. And then we also see the body producing or kicking in some of these compensatory mechanisms, largely within the sympathetic nervous system as well as the renal system, to, again, try to compensate for this circulatory failure. So again, there are four types of shock. So the first picture kind of up here shows just really normal circulation, right? We have a venous side and we have an arterial side. Oxygenated blood within the arterial side, deoxygenated within the venous side, everything kind of moving equally. And so in the first picture, we have what we would term cardiogenic shock. And essentially, cardiogenic shock is pump failure. So we've lost so much of the overall pumping function of the heart that we can't perfuse, and that leads to shock. So this is usually caused by things like severe myocardial damage, like in a big myocardial infarction, or someone who has a big myocardial contusion that's maybe traumatic in nature. It can also be caused in maybe cases where patients are experiencing like a sustained arrhythmia. So the electrical activity of the heart no longer supports good forward flow of the of blood, leading to cardiogenic shock. It can also happen if there is a really acute valve damage or a ventricular septal defect that occurs acutely. And it can also occur following things like major cardiac surgery, where the myocardium becomes kind of stunned and can't, um, maintain significant perfusion. Another type of shock is hypovolemic shock. And in this type of shock, we have low circulating blood volume. So this can happen with a significant loss of blood or significant loss of plasma, or a significant loss of extracellular fluid. Obstructive shock happens when there is an inability of the heart to fill properly, like in the case of maybe cardiac tamponade, where the pressure inside the heart gets so high that it can't fill. Or it can be caused by obstruction to outflow from the heart. So maybe something like a pulmonary embolus, or a cardiac myxoma, or a pneumothorax, or a dissecting aneurysm might all be causes of obstructive shock. And the final type is distributive shock. In distributive shock, we have this excess of vasodilation throughout the body. So all of the vessels, blood vessels within the body, become very dilated. And as they dilate, the blood kind of all just sits and pools in the systemic circulation and doesn't return to the heart. So this can happen if there's an overall loss of sympathetic vasomotor tone. We also sometimes call that neurogenic shock. But normally, you have that kind of tone or constriction of the vasculature. And if that goes away because of some kind of neurological disorder, the blood all just kind of pools and sits. It can also happen when there is the presence of a vasodilating substance in the blood. And so this is what happens in anaphylactic shock, where we get this massive vasodilation because of a substance in the body that's causing anaphylaxis. It can also happen because of massive release of inflammatory mediators. And we call this septic shock, where we get massive vasodilation. So again, just to kind of recap that, distributive shock, that happens when we have vasodilation, can be neurogenic in nature. it can be from anaphylaxis, or it can be from sepsis. So a little bit more about cardiogenic shock. So a little more about the pathophysiology. Again, it's usually caused by a MI or myocardial infarction, where we get this significant pump failure with poor perfusion. The poor cardiac output is usually a result of decreased myocardial contractility, and also increased afterload and excessive preload. Usually in cardiogenic shock, the systemic vascular resistance increases, so the blood can't pump forward from an already weakened heart. But the blood kind of keeps coming in and it can't leave the left ventricle, so then we get this big increase in preload. Um, the clinical manifestations we see in our patient are hypotension, hypoperfusion. They may become cyanotic and experience severe neurological changes. Their urine output usually drops pretty significantly. Um, Treatment of cardiogenic shock. In this type of shock, we have to try to really strike a balance between improving cardiac output and also reducing the workload and the oxygen needs of the myocardium. Because again, this is shock caused really by pump failure. And we also have to make sure we have good, adequate coronary perfusion. So if it's an MI, we would have to restore that. But we have to be very careful with fluid volume in cardiogenic shock. It needs to be really tightly regulated to maintain um, good filling pressure and to optimize stroke volume in people who are fluid overloaded. So there are many types of shock that we treat aggressively with fluid. This really isn't one of them because we already have significantly increased preload and afterload, and adding in large volumes of fluid is often really not helpful in the treatment of cardiogenic shock. But we may use things like maybe vasodilators to reduce afterload. We might use inotropic medications that help to increase contractility of the heart. We might use a device called a balloon pump that can sometimes help increase cardiac coronary artery perfusion to help the heart to work better. But again, really not a place for a lot of fluid resuscitation and cardiogenic failure. Then we'll talk about hypovolemic shock. So the pathophysiology here, so this is usually caused by a significant increase in the amount of blood lost or removed. So it usually starts to happen when we lose about 10 to 25% of blood volume. And as blood volume drops, stroke volume also drops. Um, for a time, as that stroke volume drops, we can kind of compensate to keep our arterial pressure up with sympathetic mediators. So we'll increase our heart rate, increase some vasoconstriction. Um, that vasoconstriction can result in increased diastolic pressures, and then it starts to narrow our pulse pressure. Um, If you remember, blood pressure is the product of cardiac output and systemic vascular resistance. So as those things go up, our blood pressure also goes up. Um, in hypovolemic shock, the clinical manifestations we usually see are things like thirst, increased heart rate because of that sympathetic output, cool and clammy skin. They usually have a decrease in their arterial blood pressure, urine output drops, and they get changes in mentation and level of consciousness. Their pH often drops. They start to develop an increase in lactic acid. As they go to more anaerobic respirations, their respiratory rate increases as they become more acidotic, and they usually become pretty agitated and restless. In hypovolemic shock, because this is really a loss of blood volume, treatment is directed toward correcting or controlling whatever the underlying cause is of that loss of volume, and then trying to improve tissue perfusion, restore good blood flow to the systemic circulation, supporting oxygen to try to prevent severe hypoxemia. One thing that we try to avoid in the treatment of hypovolemic shock, you don't want to use any kind of vasoconstricting agents in these patients until you really aggressively restore their blood volume. You don't want to constrict the vasculature any further than it already is, happening because of low blood volume. You really need to correct blood volume issues first, and not use any vasoconstricting agents as first-line treatments. Okay, with obstructive shock, this is usually circulatory shock that's happening because of a mechanical obstruction of the flow of blood through the central circulation. So there's something in the way. So again, it can be something like a dissecting aortic aneurysm. It can be cardiac tamponade, a pneumothorax, an atrial myxoma, which is a tumor, or it could be evisceration of abdominal contents into the thoracic cavity. And so if you're dealing with an obstructive shock, really the best way to treat this is by trying to relieve that obstruction. So again, the pathophysiology, obstructive shock describes circulatory shock that results from some kind of mechanical obstruction of the flow of blood through the central circulation. So that can be disruption of the flow of blood through the great veins, through the heart, through the lungs. The primary physiological result of obstructive shock is elevated right heart pressures because of impaired right ventricular function. Um, Pressures continue to increase even if venous return is sufficient to the heart. These patients start to develop signs of right-sided heart failure, things like elevated jugular venous distension. Usually treatment for obstructive, again, focuses on correcting the cause of the disorder, frequently with things like surgical interventions like pulmonary embolectomy if it's a PE, pericardiocentesis if it's being caused by cardiac tamponade, correction of a tension pneumothorax if that's the cause, um, whatever we need to do to relieve that obstruction. And then there's just, again, distributive shock. So we have that in kind of three separate categories. It can be septic shock, which is a systemic response to infection. It can be neurogenic shock, which is this decreased sympathetic control of blood vessel tone, or it can be anaphylactic shock, which causes vasodilation of the arterioles and the venules because of vasodilator substances like histamines, cytokine release. So three different kind of categories of distributive shock. So pathophysiology, distributive or vasodilatory shock is characterized by a loss of blood vessel tone, overall enlargement of the vascular compartment, and displacement of vascular volume away from the heart and the central circulation into the peripheral circulation. Um, so usually we call this also normal volemic shock. The overall volume of the blood within the body hasn't changed. It's just become redistributed away from, again, the central circulation, and that's what ends up disturbing overall perfusion in the body. Neurogenic shock within distributive is relatively rare, and it's usually pretty transitory. If we're dealing with something like septic shock, treatment really focuses on treating that underlying infection to try to reduce that kind of vasodilatory effect. Same thing with anaphylactic shock. You need to reverse the anaphylaxis. And in both cases, both septic and anaphylactic shock, we treat with a lot of fluid resuscitation. One other thing I would mention is a differentiating feature of these types of shock compared to like obstructive or cardiogenic types of shock. And these type of shock in septic and anaphylactic shock, the skin is usually kind of warm. Um, so one way to tell the difference. Septic shock usually manifests with things like hypotension, warm, flushed skin, whereas other forms of shock like cardiogenic, hypovolemic, and obstructive are usually characterized by compensatory increases in systemic vascular resistance. So that looks like kind of that cold, clammy skin in those patients. So some overall complications of shock, several different categories. It can be pulmonary injury, acute renal failure, gastrointestinal ulcerations, disseminated intravascular coagulation or DIC, and multiple organ dysfunction syndrome or MODS. So with acute injury, acute lung injury, ARDS, we've talked about these. We talked about this in the respiratory unit quite a bit, but this is a potentially lethal form of pulmonary injury that can be either the cause of or the result of shock. This usually has a pretty rapid onset of profound dyspnea that usually happens about 12 to 48 hours after the initiating event. Um, and usually, we talked about kind of the definitions and the focus of interventions in the pulmonary unit. So I would just kind of defer to that conversation for the rest of this piece. Shock can also cause acute renal failure, usually because of impaired renal diffusion or direct injury to the kidney. The degree of renal failure is usually related to the severity or the duration of the shock. So if you remember the causes of AKI, one is pre-renal causes. So if we have a significant decrease in perfusion to the kidneys, that can cause acute renal failure in a patient with shock. There are also gastrointestinal complications, things like loss of appetite, nausea, and vomiting. We get a big drop in perfusion to the GI tract, so it slows down peristaltic activity, which can lead to kind of the nausea, vomiting, appetite things that we see. It can also start to cause superficial mucosal lesionings of the stomach and duodenum. And so for patients in shock, we need to do a lot of preventative medications and work to keep these patients from developing any severe gastric ulcers. And shock can also lead to significant ischemia and necrosis of the bowel or GI tract because of hypoperfusion. Disseminated intravascular coagulation can also happen. I'm sure remember what that is, but this happens when there's a lot of systemic formation of thrombosis. We get a lot of um, kind of widespread coagulation, and then using up of clotting factors is a relatively common complication of shock. So the final thing we'll talk about is multiple organ dysfunction syndrome, or MODS. So this is a pretty ominous complication of shock. It's usually a pretty bad sign when someone starts to develop multiple organ dysfunction, meaning, the kidneys start to shut down, the liver starts to shut down. We see alterations in the GI tract, kind of just all over. This rapidly depletes the body's ability to compensate and recover from a shock state. So if someone is already in shock, they're working through a lot of different compensatory mechanisms in an attempt to adapt all these perfusion changes. And as organs start to fail, it makes it even harder to do that. So again, it can affect multiple organ systems: lungs, kidneys, liver, brain, and heart. People more likely to develop MODS in septic shape or in uh, states of shock are people who are in septic shock, anyone who's had a hypotension for a prolonged period of time, people with underlying hepatic dysfunction, people with infarcted bowel, older patients, anyone with severe trauma, or anyone with a history of alcohol abuse. So just some overall treatment measures to correct and reverse shock. One big one is fluid resuscitation, but remembering that that's not necessarily helpful in things like cardiomyopathy or obstructive shocks. We also need to restore blood flow to the body, increase perfusion. We need to improve oxygen delivery and work towards improving kind of this overall hemodynamic stability. You'll talk quite a bit more about shock and its diagnosis and treatment in your advanced kind of acute care course in your final year.